Hello, everybody. This is Irma Jennings, the Osteoporosis Navigator. If you like this video, my educational video on osteoporosis, do me a favor, please. Kindly subscribe right down below, like my video, share my video, and make a comment. And this way I'll be sure to respond to your comment. This helps circulate the video to bring education to a larger group of people. Thank you so much for doing that. Hello, everybody. This is Irma Jennings, and I'm very, very happy to have you all here. And I'm really honored to have Dr. Lewiecki spend time with us and educate us. And I will say a couple of things. Dr. Lewiecki is the director of New Mexico Clinical Research and Osteoporosis Center and clinical assistant professor of medicine at University of New Mexico Health Sciences Center. He's a certified densitometrist, which means that he's trained in reading the DEXA test. And his office also has a DEXA with a TBS, trabecular bone score, that reads the inner part of the bone, just to be really sort of common in description. So my capacity in my role as an osteoporosis navigator, I encountered Dr. Lewiecki while seeking a specialist in bones for a client that was transitioning from Florida to Albuquerque, New Mexico. And the client had a rather complex case requiring a physician with real exceptional expertise. So while advocating for my client, I was struck by Dr. Lewiecki's remarkable blend of compassion, patience, and genuine care, which I think you'll hear will come across on the call. And Dr. Lewiecki runs weekly meetings with doctors, researchers, and cutting-edge osteoporosis tools, I would say, are presented and discussed. There are at least 100 people on those calls every week from around the country. And he also does 2 case studies per week. So they're presented and they're discussed. So Dr. Lewiecki, what else would you like us to know about you?
Well, we have people here from all over the country. So I see there's somebody from Boston. So I'm from the Boston area. I grew up in a town called Hingham. I made my way to Chicago to go to medical school, and then I did my residency in Albuquerque and at University of New Mexico, and ended up marrying a local girl, and was trapped in New Mexico and could never go back home to Boston. So I've been here ever since, and that's why New Mexico is called the land of entrapment.
Oh,
so sometimes it's because of marriage, sometimes it's the beautiful weather and the mountains that keeps people here. But anyway, I still get back for a Red Sox game every summer at Fenway Park.
and you've been in the osteoporosis space since what year?
Well, I started off doing general medicine, but I got very interested in osteoporosis in the early 1990s, and it really has taken over my professional life. So all I do now is involved with osteoporosis and other sorts of metabolic bone diseases, and that's what I do all day long, and I even dream about bones sometimes.
Okay, all right. This is important for us to know. I'm going to kick us off with a question that's really been troubling me for a long time. And this is, by the way, we're not going to do case studies here. We're going to have general questions. This is a general questions, although it's related to me. So that sounds a little self-serving, but here we go. I was under the illusion that my bones were strong. I've been getting DEXA tests every 3 years, every 2 years, same facility for several years. And my bones kept getting stronger and stronger. I'm 71. And I was thrilled because I thought I was doing everything right. And that's that's a comment that most people say. I thought I was doing everything right. But my L1 through L4 was 0.0. So I felt like a teenager. And my TBS, my trabecular bone score, was 1.392. So that indicates strong, as I understand it, inner bones or the bone architecture. And my FRAX, the 10-year probability for an osteoporotic fracture was 11.3. And then for the hip, it was 2.1. And then if you take in the TBS, the probability was a 10 10-point osteoporotic fracture, and the hip is 1.8. So all is going well. I think I'm doing a great job. I'm getting my CTX done because I want to. So my CTX was in the 304 to 435 range. P1NP, I'm not on medication. I did it because I wanted to. So it ranged from 34, hit 54, and then 40. But then I had the echo light done, and I know you've spoken about the echo light because I was very curious to see, like, why are my bones so strong? And there was no indication from my endocrinologist that I had arthritis, or primarily that made the bones look stronger. So I had the echo light done just to get another opinion. And it showed that my L1 through 4 was a negative 2.5. So I was an osteoporosis there, and also in my hips. The risk of fracture for the spine was 6 to 10% over 5 years, and hips was 5% over 5 years. Echo light shows a fragility score of 49 for my spine, 0 to 100 is the range, and 49 was right in the middle. So my question is, if in fact we're looking at the bone mineral density, the DEXA tests, doctors cannot get the full report. So they're looking at the 2-page radiology report, which is not giving them enough information. And many times doctors are prescribing based on that. So it's sort of a two-part question, which is, what do we do about DEXA? I know you've had this question before. And then what about the 2-page report that why is it so difficult to get a full report with the images?
Well, I'm not going to talk about you,
Right.
but I'll talk about DEXA
Mhm.
and echo light.
Right. Thank you.
Okay, so DEXA is very simple from a patient's point of view. Of course, you just lie down on the table and the machine does the scanning. But it's complex in doing it correctly and accurately and interpreting correctly. And the spine in particular gets to be a problem in measuring bone density as we all get older, because everybody gets some osteoarthritis in their spine. Plus, sometimes we have scoliosis, sometimes we have disc disease. And those things can result in calcium deposits in the spine that make the bones look more dense, even though they're not very strong. So the spine is often not such a good place to measure bone density as we get older. The hip, even when we get osteoarthritis in the hip, is a much more reliable place to measure bone density as we're older. So we put more stock in that. Of course, it has to be analyzed correctly and interpreted correctly. And it's really the gold standard for measuring bone density and determining bone strength. Now, there's a new technology that you mentioned called echo light. This is ultrasound. It's not the same technology as DEXA. And in theory, it gives us numbers that are equivalent to DEXA. And it's something that's been developed in Europe and in Italy, and it is used some places in Europe in clinical practice, but not so much in the US. There are a few places in the US that are experimenting with echo light. In fact, we've done it here at our research center. We had an echo light instrument for several months, and frankly, it was our experience that the correlation with DEXA was not so great. And we had a similar experience as you did, Irma, that bone density looked not so bad with the DEXA. And then when the patient had an echo light ultrasound measurement, the bone density looked very low. And so, frankly, I put my trust in the DEXA more than the echo light, but I'm not really sure about that. And I think we just have more to learn about echo light and accurate it is. So we may be hearing more about it. There may be more machines used to do echo light around the US. And as everybody gets more familiar with the technology, we might end up doing it more. But right now, DEXA is still the gold standard, and that's what I put my faith in right now. I may tell you something different next year if we learn more about it.
Okay, okay. But what do you say to the patient, not me, the patient who has a good score, but it's not accurate at we're using the gold standard and it's an absolutely great test that I had. So what do you say about that?
Well, it is accurate. DEXA is remarkably accurate. Probably I'd have to see what the spine looked like, but probably there's some arthritis in the spine, and so we just don't pay any attention to the spine in a lot of older people. Once you're over 50 or 60, you start to get arthritis in your spine. So we put a lot more into what the hip measurement says, and with the FRAX calculation, we use the hip bone density, not the spine. And FRAX has been validated in very large populations. Hundreds of thousands of patients have been used to get the data that goes into the FRAX calculation. And that gives you an estimate of your 10-year probability of having what's called a major osteoporotic fracture and the 10-year probability of a hip fracture. So we use those numbers often to help us decide who needs to be treated. And in fact, in Europe, FRAX is the main deciding factor in whether somebody ends up getting treated with medications or not.
And for those that are unfamiliar with the terminology of FRAX, could you just give a brief definition of that, please?
Yeah, FRAX is a fracture risk calculator. It is available online. It comes out of Sheffield University in the UK. And any of you could go on to the website right now. You could just Google FRAX and it could come up. And you could put information in there and get a number for your 10-year probability of breaking a bone. And FRAX is, that's FRAX. That's incorporated into most of the modern DEXA machines. So frequently, if the T-score values give you a diagnosis of osteopenia, then in many cases, the machine will automatically print out the FRAX calculation. And if the 10-year probability of major osteoporotic fracture is 20% or more, that's considered high. If hip fracture risk is 3% or more, that's considered high.
Oh.
The idea is that some people with osteopenia on the DEXA, that is a T-score that's between -1 and -2.5. Some of those people have low fracture risk and may not need any kind of drug treatment. And some of those people may have very high fracture risk, even though the bone density is not too bad, and they may need treatment to strengthen their bones. So FRAX helps us in making decisions about whether to recommend drug treatment or not.
Thank you. That brings us to Vicky's question. Vicky.
Hey.
Simon?
So I've heard that the number of people who fracture is greater for those who have osteopenia or a lone bone mass versus those with osteoporosis. Is this due to the greater number of people with osteopenia, or is there some clinical significance related to the greater number of fractures?
Well, the lower the bone density, the greater the risk of breaking a bone. So in general, if you have osteoporosis, your risk of breaking bone is going to be higher than somebody with osteopenia, if all things are otherwise the same. However, as you said, there's a lot more people with osteopenia than with osteoporosis. So even though the fracture risk is higher as bone density goes down, if there's 3 times as many people in the world with osteopenia as osteoporosis, the total number of fractures will be higher in that group. And in fact, that's exactly the reason that FRAX was developed in the first place. Because if we only treated people who had osteoporosis according to T-score, we would miss an opportunity to treat many people who might otherwise go on to have a fracture, but not be treated if we just looked at bone density alone. So we look at FRAX and other things called clinical risk factors for fracture, and put all of that information together before we decide who might need to be on a drug and who might benefit the most from it.
Okay,
Okay, thank you.
thank you.
Jan, do you want to talk about reclassed? Take yourself away.
Yeah, thanks, Irma. And I have a couple questions, Dr. Lewiecki. And it's really great to have you here. I really appreciate it. So the first question is not exactly reclass, but is I've had multiple fractures of the spine since 2019. And I'm wondering, what does the research show, or what you've learned in your practice on how to decompress the spine long-term after multiple compression fractures?
Well, there really is no decompression of the spine that I know of. A fracture means that a vertebral body is crushed. A vertebral body normally looks like a square or a rectangular block, and with a fracture, it's squished. So the height of the vertebral body is diminished, and normally it's going to heal. It's going to, over the course of 6 or 8 weeks, it'll heal up with that new shape that is shorter than it was before. And that can affect you by changing your posture, or you can lose height overall. You can end up having a stooped posture or a curved back. And all of those things are going to stay there. Now, you can improve your posture. Physical therapists sometimes will, work on giving you exercises to strengthen your back muscles, and perhaps by making your posture a little bit better, that might help some. And there's a procedure called kyphoplasty, which involves passing a needle into your vertebral body that's fractured and blowing up a balloon inside the vertebral body, and then filling up that space that's been created with cement, bone cement called polymethylmethacrylate. And in theory, that can restore some of the lost height in the vertebral body. So in that sense, that might at least partially, reverse the loss of height that's occurred. It's not real reliable that it can do that, but at least in theory, you can gain a few millimeters of the height that was lost from the fracture. And that also is an effective way of relieving pain in most people who get it with an acute fracture. So did I answer your question, or?
Yes, I was afraid that was the answer. I think, it would be great if I, hung from a pole and could, at least that does help for a little while. But, if you build muscle, you'd have to hang from the pole a long time, to, once as it's healing, but, that's not possible. Anyway, yeah, thanks for that. And my second question relates to reclass. So when I first started having the fractures, I was diagnosed or recommended the reclass medication, which I took for 3 years, and last year finished the 3rd year. And now with my new bone density tests and some more fractures, the endocrinologist has said I should do 10 more years of reclass, which is not appealing at all to me. But is that, I don't know if you have to look at my medical record, but is that something that's wise to continue doing that for 10 years?
Well, again, I'm not going to talk about you, but I will talk about reclass. So first of all, there's no time limit to reclass. It's approved by the FDA for the treatment of osteoporosis, given once a year. And there's nowhere that it says you have to stop that once a year at any one time point. However, what is commonly done in clinical practice now is when somebody has osteoporosis, we'll give it once a year for 3 years. We'll reevaluate things. If there's a good response and fracture risk is no longer very high, we may try to stretch out the time between doses to longer than a year. And we can do that because this type of drug called a bisphosphonate attaches to your bones, it gets buried in your bones, and it continues to work for a long time, even if you haven't received any new medicine for quite a while. So sometimes we'll give 1 dose or 3 doses or even 6 doses sometimes once a year. And then we might be able to go 2, 3, 4, 5, or 10 years before you need any more. And in fact, in some research studies in women with osteopenia, at least, 1 dose of reclass that has lasted as long as 5 or 10 years as far as having beneficial effects on the bone. Now, you bring up a whole nother issue besides reclass, though, and that is somebody who's had multiple fractures is in a category of very high risk for future fractures. And we have a whole class of drugs that are recommended for consideration anyway in patients who are at very high fracture risk. And those are the bone building drugs. So a lot of you have heard of those. They're called Forteo, Tymlos, and Evenity. And they're the big gorilla for osteoporosis treatment. So the ideal thing for somebody with very high fracture risk is to start out with a bone building drug and take that for 1 or 2 years and then follow that up with one of the standard anti-resorptive medicines, and that might be reclassed or it might be Prolia in many cases. But for somebody at very high fracture risk, we always think about the bone building drugs. Now, we can give bone building drugs after taking reclass or one of the other medicines, but the effects will be a little bit delayed or a little bit more modest because of the previous therapy. So the concept here is that the sequence of therapy makes a difference. And if somebody's recognized at very high fracture risk, the ideal way to treat it is to begin with a bone building drug that will improve the structure of the bones as well as the bone density, and then follow that up with one of the other medications to maintain or improve the bone that's been built with the bone building drug.
In your experience, should the patient be off of reclass for X amount of period of time before they go on reclass, Evenity or another anabolic?
Well, the ideal thing is to begin with Evenity in the first place if you're thinking of using it. So that's the best way to do it.
But if not, if they have a history of reclass and it's not working and their endocrinologist is suggesting an anabolic, should there be a pause on the reclass for a year or 2 or not necessarily?
Well, no, not necessarily. Actually, there's been some studies that show combining a bone building drug and something like reclass may actually have an additive effect.
Okay.
We don't generally do that. We don't usually like to give 2 different drugs for the same thing at the same time. So normally, if we're going to go to a bone building drug, we'll begin that a year after the last dose of the reclass.
So the bone building drugs that Dr. Lewiecki is referring to are called anabolics, and they are Forteo, Tymlos, and Evenity. So Connie, can you take yourself off of mute and ask your Evenity question?
I know that there are issues with cardiovascular events, possible events, and Evenity, but in some instances, so that anyone who has a heart condition should not take Evenity, but in many instances it can be hidden. A person doesn't know if there is a heart condition. So my question is there any kind of warning? Are there any symptoms if someone is taking Evenity? I mean, can they just have a heart attack out of the blue? Or is there any kind of warning?
Well, let me tell you what we know and what we don't know about all of this.
Mhm.
So the biggest research study with Evenity was called the FRAME study, FRAME. And there were over 7,000 women in that study. And half of them got Evenity and half of them got a placebo. And they were followed for many years. And the result was for cardiovascular events, there was no difference at all. The people who got Evenity had no more heart attacks and strokes than the people who got placebo. So it looked very safe from a cardiovascular standpoint. Then there was a smaller study called the ARCH study, ARCH. And that study had half of the women taking Evenity and the other half taking Fosamax. And in that study, there was a numerical imbalance of cardiovascular events where there were a few more women who got Evenity who had heart attacks and strokes compared to the women who got Fosamax. And the finest researchers in the world reviewed all this data, trying to figure out why there was a difference in cardiovascular events in the two studies. And frankly, they couldn't come to a conclusion. They really didn't understand it. And they thought perhaps Evenity might increase the risk of cardiovascular events. Perhaps the Fosamax reduced the risk of cardiovascular events. And perhaps it was just a statistical fluke, because if you study enough patients for enough things, you're bound to have some differences. So the bottom line is there's uncertainty about the risk of cardiovascular disease in people taking Evenity. But to be overly cautious, the FDA required a boxed warning that went along with the medication saying that it may increase the risk of cardiovascular disease. That also means it may not increase the risk of cardiovascular disease. And they recommended that if you had a heart attack or a stroke in the last year, that you should not take the drug. So in general, you know, we follow that. But as with all medications and everything in life, what we do is a balance between the expected benefits and possible risks. So when you walk across the road at an intersection, you're figuring that you're going to make it to the other side before a car runs a red light and mows you down. So you do a risk-benefit analysis and you decide it's safe to cross the street. Well, with drugs, it's the same way. There may be people who are concerned about cardiovascular disease, but it could be that the risk of having a broken bone if they don't get this drug is so high that the balance of benefits and risk is in favor of taking the drug. And in the research study that ARCH that showed a numerical imbalance in cardiovascular events, there was no way to predict who got a heart attack or a stroke and who didn't. And that was looked at in many different ways. So was it older people? Was it people with diabetes? Was it people with high cholesterol? Was it people with high blood pressure? Was it people who were fat, who got the heart attacks and strokes? And frankly, there was nothing that identified those particular people. It just could have happened to anybody. So to answer your question, there's not any warning. And of course, this drug is mostly given to older people anyway, who might get a heart attack or a stroke, whether they take the medicine or not. But if somebody does get a heart attack or a stroke while they're taking the medicine, it's advised to stop the medicine, and that's what we always do.
Mhm.
So
And do you-
anyway,
do
we
you-
have that discussion about uncertainty with all of our patients before we start the drug.
And is there a cardiac workup that one should do before they're considering Evenity?
Nothing that we know makes a difference.
You
Hmm.
I
mean,
mean,
even
you
if you,
certainly do that, but a cardiac, workup might be, well, you could have a treadmill test, or you could do a coronary calcium score. You could check your blood pressure and your cholesterol, all of that kind of stuff. But frankly, nobody knows if that makes any difference in whether you're going to have trouble or not while you take the medicine.
and you had commented at one point about Medicare reimbursing for Evenity. Can you speak a little bit about that, please?
Well, I'm not an insurance expert, but my understanding is that if you have Medicare primary, and then you have a supplemental policy, that Medicare will cover 80% of the cost of the drug, and your supplemental policy will cover 20%, assuming it's a decent supplemental policy. So it's covered very well. It's different if you have a Medicare Advantage plan, which can set their own rules, and they may not cover it at all, or they may cover it with a very high copay that's more than you want to pay. And if you have commercial insurance, if you're not on Medicare, then the commercial policy makes up all the rules about that too. So you just have to understand what your individual insurance will cover. But generally, for people with Medicare primary insurance, it's very good from a cost standpoint.
And is that because has to be issued in a hospital, or is that one of the reasons why?
It's, well, Evenity is classified as Medicare Part B, as in boy, because it's given in a doctor's office or medical facility.
Okay.
And Medicare covers Part B drugs. Drugs that you take at home are under Medicare Part D, as in dog.
Mhm.
So for instance, the other bone building drugs, Forteo and Tymlos, are drugs you give yourself at home. So it depends on your Medicare Part D policy, how well they're covered and what your copay is going to be.
Okay. Connie, was that it? Are you complete?
I had a question about the effect of Evenity on sclerostin, and the possibility, I've read of the possibility of degeneration of muscle down the road. Now, is that, I know Evenity hasn't been out that long, so is that just speculation, or has that been seen?
Well, as far as I know, that's not been a recognized problem. So just to explain to everybody, sclerostin is a small protein, a molecule that inhibits bone formation. It's produced by a bone cell called an osteocyte that's buried inside of all of our bones. And when there's a lot of sclerostin around, you have less bone formation, and that can contribute to having osteoporosis. So what Evenity is a monoclonal antibody to sclerostin. So a lot of drugs now are monoclonal antibodies. And I think of it as like an anti-missile missile. If you think of sclerostin as a missile that's aimed at inhibiting bone formation, you knock out that missile with your Evenity, and therefore you're inhibiting an inhibitor, and you're stimulating bone formation. So that revs up your osteoblasts to produce more bone and improve the structure of your bones. Now, there is also a little bit of sclerostin in other parts of our body. We're still learning more about that. And there's a thought that if you inhibit sclerostin in other places, that might have some unexpected effects. And frankly, I think we're still learning about that. So I have not seen any good evidence that Evenity is harmful to muscle function, but who knows? Maybe we'll learn more as time passes.
Mhm. Okay, thank you.
Anne, do you want to come on and ask your question? Thank you, Connie.
Thank you.
Anne, can you unmute yourself?
That would be a good idea. Thank you for being here. Thank you for being here to educate us. I'm very interested in knowing what factors you consider, like what an intake looks like. If I were to come to you, for example, what kind of tests and what are you looking for besides the DEXA? I know that the DEXA is the gold standard. I heard you say that. So what else would you be looking at in an intake?
I'll tell you the most important thing. I'd ask you, have you ever broken a bone? The most robust predictor of future fractures is having a previous fracture. And in fact, if you've broken a major bone as an adult, we're probably going to say that you have osteoporosis, no matter what your bone density shows. And another nuance to that is that you may have a broken bone and not know that you have a broken bone. So one of the things that we do with the intake is measure somebody's height. And we get a very accurate height measurement. We do it with something called a wall-mounted stadiometer. So it's just a simple device that's attached to the wall that gives us an accurate height. Supposedly it measures height to the nearest 0.5 millimeter. And then we ask you, what's the tallest you ever were when you were in your 20s, for example? And you may be shocked to discover that you've gotten shorter. And if you've lost 1.5 inches in height or more, there's a possibility that you could have a fracture in your spine that's at least partially responsible for that. So in that case, we like to get a picture of the spine to find out if there's a fracture. If there's a fracture, that tells us that your risk of breaking bones is higher than what we thought it was before, and it might lead us to treat with medication where we wouldn't have treated otherwise, or maybe to treat more aggressively, maybe with a bone building drug instead of one of the regular drugs. So having a prior fracture is extremely important. We also do some simple lab tests on everybody. We like to measure some blood chemistries. We want to be sure your calcium level in your blood is okay. Some people have a high calcium from a disease called primary hyperparathyroidism. And primary hyperparathyroidism can be a cause of osteoporosis. So if we find that, perhaps treating the primary hyperparathyroidism is all that's necessary for treating the osteoporosis, and it might get a lot better once that's fixed. We like to check a vitamin D level. Vitamin D deficiency is not good for bones, and it can cause bone pain if it's severe enough and contributes to osteoporosis. We measure kidney function because some of the medicines like Fosamax and Reclast should not be given to people with severe kidney disease. We always measure a phosphorus level because some people have phosphorus levels that are too low, and that can contribute to bone disease. We need to find out why the phosphorus is low and fix that. And in some cases, we'll do a 24-hour urine collection to measure a calcium level. That tells us whether you're absorbing calcium okay or not. Some people get enough calcium, but don't absorb it, and that can be a cause of osteoporosis. So we like to do that. Sometimes we measure tests called bone turnover markers. So there's two of them that we use a lot. One's called CTX, the other is P1NP. They are indicators of your rate of bone metabolism. And people who have high bone metabolism tend to lose bone faster than other people, and it can make the bones weaker. And sometimes checking those bone turnover marker tests can tell us whether the effects of your previous medicine are still lasting or whether the medicine is working well or not. And we measure proteins in some people. So there are diseases such as multiple myeloma that can cause osteoporosis. That gets more common as we get older. And sometimes we measure the proteins to be sure there's nothing like that going on. And there's other things too, but that's kind of the basics that we think about.
What kind of vitamin D levels are you looking for when you are measuring that?
Well, I'll tell you what we do and what most of the societies that deal with osteoporosis recommend, but there's controversy, so you're going to get different numbers from different people. But the most standard range that's targeted is between 30 and 50. That's nanograms per milliliter. So if you're somewhere in that range or close to that range, you're probably okay. If it's over 50 by a little bit, that's not a big problem. Vitamin D is very safe. If it's a little bit under 30, that's probably not a big problem. But if it's extremely high or extremely low, that can cause problems. So we certainly want to avoid the extremes.
Thank you. This question is coming up a couple of times in the chat as far as calcium. Somebody's on Timlos. Can they take calcium while on Timlos? Calcium supplement?
Well, no matter what drug you're on, it's important to have an adequate intake of calcium and vitamin D.
Mhm.
That goes for all of us with all drugs. Now, Timlos and Forteo can occasionally make the calcium level in the blood go too high. That's a potential side effect of the medicine. So we like to measure the calcium level once in a while in people who take these drugs. And if it is too high, we can often correct that just by cutting down on your calcium intake. So that's something that has to be monitored.
Okay.
So generally that can be handled. With Timlos, there's something kind of interesting too. We can actually adjust the dose on the Timlos. And sometimes if the full dose is causing the calcium to go too high, we can give a lower dose and correct the problem that way. And we hope that the medicine still has its full effect to help with your bones, even though the dose is lower.
And that's a beautiful thing about Timlos. It's the pen that you can click down, right? As far as lowering the dose.
Yeah, Timlos is a medicine that's you inject yourself at home into the fat in your stomach, and it comes in a pen that has a 30-day supply. There's a little knob at the end of the pen, and each time you give yourself an injection, you turn the knob all the way, and it gives 8 little clicks that you can feel. And that gives a dose of 80 micrograms, which is the normal dose. But some people have problems with that. It could not only cause a high calcium, it might make you feel lightheaded or dizzy or give you a feeling that your heart is beating fast. So in those situations, we'll sometimes tell people to turn it 4 clicks instead of 8 clicks. And that gives a half dose approximately. So we're about 40 micrograms instead of 80 micrograms. And we have ways to check to see if that's as effective as we'd like and tolerated better. And once we find a dose that works, we have people try to go up a little bit more if possible. And we find the highest dose that's tolerated that does the job. So it's a nice way to work with that particular medicine.
Thank you. And the kind of calcium that you recommend in general, do you go with carbonate or do you go with citrate?
What I recommend is food, number 1.
Yay, me too.
So food is good. Dairy products are the easiest way to get it. If you can get 2 or 3 servings of a dairy product every day, you probably got all the calcium that you need, assuming that you're absorbing it okay. If you take a multivitamin for seniors, that's typically got about 200 milligrams or so of calcium. So that's a little extra insurance that you're getting enough. Now, if you're doing everything possible with your diet and you're not even coming close to the recommended 1,200 milligrams a day, then you do need supplements. And there's two basic kinds, calcium carbonate and calcium citrate. They're both perfectly fine. The main difference is calcium carbonate, which is things like Tums or Caltrate or Oscal. That should probably be taken with food to help it to be absorbed. The calcium citrate or Citracal can be taken with food or without food. So it's a little bit more flexible. So if you want to carry your calcium pills in your purse and plop it down in between meals, calcium citrate's fine. It should be absorbed without any difficulties.
I just have to say that so many of my clients come with gut issues, and I don't know about the ability, I can't get into the gut to see whether or not they're absorbing the calcium carbonate because of so many gut issues. So it seems that an easier one may be the calcium citrate.
Yeah, it may be a little bit better tolerated by a lot of people. Some people get constipated taking calcium pills, and the general feeling is that maybe calcium carbonate is a little bit more constipating. You can get liquid calcium, you can get chewable calciums. It comes in all different forms, and some people just have to experiment to find what works best for them.
Okay, thank you. Barb, are you there? You want to ask your Prolia question? And you see that time is ticking away quickly, so we need to be very concise. Barb, are you there?
Yes, here I am.
Mhm.
Hi, Dr. Lewiecki. Thank you so much. I'm learning a lot. I've had 2 wrist fractures. So I was put on Prolia, and I was on Prolia for 5 years, very successfully. My DEXAs got better and better and better, and I went from osteoporosis to osteopenia. My doctor recommended that I move on to bisphosphonate, which was reclassed. And I took the reclassed and ended up having an allergic reaction to it. And the reclassed infusion was done 6 weeks past my Prolia, what would normally have been a Prolia injection. And as a result, I had the rebound bone loss because my next DEXA showed that everything had reversed. So I'm back on Prolia. My question is there an off-ramp for me with Prolia? Because I am concerned about the fact that it's inhibiting my osteoclast to the point that it's doing damage if I try to go off it again. And I don't know if the damage that has already been done can be, what's the word? Rebuilt, I guess, for lack of a better word. I don't know what my choices are at this point. I do have kidney issues, so I know there are things that I don't want to look at, and I understand from what you said in a previous interview that Prolia is pretty kidney friendly. So that's my question, if there is an off-ramp. And thank you.
Well, you're asking the same question that a lot of osteoporosis experts are asking each other. So we're all struggling to deal with this. Let me say one thing about your opening remarks. Once you have osteoporosis, you
Yeah.
always have osteoporosis. So even if your bone density gets fabulously good, the osteoporosis hasn't disappeared. Your diagnosis is still osteoporosis. It's just the same. If you have diabetes and you take a medicine and your blood sugar comes down to normal, the diabetes hasn't disappeared. You've got diabetes that's treated, and it's the same with osteoporosis. Now, you had an allergic reaction to reclass. The most common reaction to reclass is what's called an acute phase reaction, and those are flu-like symptoms where you feel feverish or achy or have sore muscles and joints. Typically, it lasts a couple of days and goes away, but sometimes it lasts longer. That is, if that's the kind of reaction you had, it's generally a one-time thing. It most often does not happen the next time, or it's a lot milder if it does.
I had hives. I got hives.
Okay, so you have a real allergy. Okay, so no bisphosphonates for you. So that whole class of drugs is out. What we know about the Prolia is that in women who have taken it continuously for 10 years, the bone densities continued to improve, and the safety profile looks real good. And so at least for 10 straight years, it seems to be fine. And there's no reason that it has to be stopped after 10 years. So many times when we start Prolia now, we think of it as a lifetime commitment. Now, normally, if you stop Prolia, and there are many reasons you might want to do that, you might have changed insurance and it's not covered, or you moved to some place where you can't find a new doctor, or had a bad reaction to it. The normal thing is to switch to one of the bisphosphonates that you can't take anymore. So sometimes that's Fosamax, but most often it's the reclassed. And typically, if you've been on long-term Prolia, like more than 2 or 3 years, and you get a dose of reclass, which may be given 6 or 7 months after the last dose of Prolia, we can expect that bone density is going to go down some. And that's what's been found in multiple research studies. When the Prolia has been taken for not so long, if it's only been taken for 1 or 2 years, generally when we switch to reclassed or alendronate, bone density remains stable. But probably the longer you take Prolia, the more likely you are to have a decrease in bone density after you stop it and switch over. We try to get around that, and we try to mitigate the bone loss by giving a dose of something like reclassed, and we check bone turnover markers 3 months later. And if they look bad, we might give a second dose of the reclassed, 3 or 4 months after the first one. And sometimes that seems to work. But we're still trying to figure out the best way to do that. And in fact, I'm on a task force that's investigating that right now. We're trying to come up with some new recommendations for doctors, and we need a lot more data to learn how to manage this properly. In a situation like yours, where you can't take any bisphosphonate, there's no good alternatives to that right now. So
Okay.
you may just have to accept the idea of taking the Prolia forever until we learn more.
Okay.
Yeah.
Thank you.
Thanks, Barb. Just because we're running out of time, Marcia, I'm going to ask Dr. Lewiecki your question. She was on various kinds of medication. She's a young woman, 56-year-old. I know we're not doing a case. She was on Forteo, then she went to Prolia, stopped Prolia, but now she's on HRT, and she went into menopause. Excuse me. She's 56 years old. The question that she's asking, have you seen hormone replacement, bioidentical hormones, instead of medication, help with bones?
Well, that's a whole bag of worms.
No.
Bioidentical hormones mean different things to different people. The strict definition of it is a hormone that's identical to a natural hormone.
Mhm.
And we have some of those. Estradiol, for example, that comes in many forms, is a bioidentical hormone. That's been tested extensively by the FDA for effectiveness and safety. We understand how to use it. You need a prescription to get it. And it works well for the right people. It can be very beneficial for bones. Now, there's something else that's often called bioidentical hormones, and those are compounded in pharmacies.
Mhm.
And these compounded preparations are not regulated by the FDA. They may vary quite a bit from one pharmacy to the next. So it's not quite so clear how safe and effective they are. Now, often these compounded hormone products are used to treat menopausal symptoms, and they may work. But the dose of any hormone medicine that it takes to help with menopausal symptoms is not necessarily enough to help to protect your bones. So you may get a compounded product from the pharmacy and you might feel great taking it, but it's a little bit of another step to find out if it's helping to treat your osteoporosis or prevent bone loss. And that's one of the situations where we sometimes use one of these bone turnover marker tests that we talk about, like the CTX. So what you want hormones to do is slow down your bone metabolism and give you a low number on your CTX. And if you get a nice low number, then you can figure you probably are getting some bone benefit from it, and maybe it's okay to continue it. If the number for the CTX is too high, it tells you that you're not getting the kind of bone protection you'd like to have, and maybe you need something more to actually do that.
Thank you. Going back to the bone markers, in general, before you put somebody on medication, do you always do a baseline of the CTX? If you're doing an anabolic, a CTX and P1NP as a baseline?
Well, I can tell you what I do.
Oh.
It's not necessarily it's not what everybody does. And there's a wide range of opinion about these bone turnover marker tests, even with osteoporosis experts. So there's some who say they order it on everybody. There's some who say they never order it. And I'm kind of in between. I order it on selected patients. I order it if there's a reason that I might get helpful information. For example, if I start somebody on Fosamax and I'm not sure that it's going to be absorbed very well, I might get a baseline bone turnover marker and then repeat it 3 months later. And I'd like that number to be a lot lower. And that'll tell me that it's getting absorbed and getting to the bones and slowing down the bone metabolism. And I often use the marker P1NP for anabolic drugs. For example, we talked about Tymlos and adjusting the dosage. What I might do is get a baseline P1NP and then get one later on if I want to know how well the Tymlos is working, especially if I'm playing around with the dose on it. Now, this is not FDA approved to adjust the dosage, but this is just something some of us do.
Mhm.
But if I do put a patient on a lower than standard dose, I'd like to know that it's still working. And if I can put a patient on a lower dose and get a P1NP number that's still very high compared to baseline, then I know that the medicine's working. And that makes me feel better about continuing with that lower dose.
Thank you. Gail, do you want to come on and ask your question and be very concise? Gail?
Sorry about that. Thank you very much for what you're doing here. I just want to follow up with something you said earlier when you were talking about FRAX scores, and that being in some cases what's used to predict whether to put people on medicine. What is considered a FRAX score that's it's time for people to move forward quickly with medicine or whatever? What's a high one?
Well, if the 10-year probability of major osteoporotic fracture is 20% or higher, or hip fracture is 3% or higher, those are considered to be high numbers.
Okay.
So that's kind of a standard that's been established. And, it's just one rough way of helping us to make decisions. I mean, there's a range of error with everything we do in life, including FRAX. So it's not the final word on everything that we do. If the fracture risk is 20%, now, we don't even know what the range of error in that is. We don't know if it's 20% plus or minus 1% or plus or minus 5%. So, and it's like any computer calculator, garbage in and garbage out. So you've got to have accurate information going into the formula to begin with to get even a semi-accurate number for your fracture risk. So that's why doctors pay a lot of attention to what information goes into the formula to begin with, to be sure we get the best possible number that comes out.
Thank you. And then two more quick questions. You had said that once you have osteoporosis, you have osteoporosis, and it's like diabetes, which I heard clearly. So if Fosamax is the path one is on, is it likely that you need to be on Fosamax forever? Or is it possible that after a period of time, Fosamax will do its work and you could just be monitored?
Well, Fosamax is in a group of medicines called bisphosphonates that are very unusual. So we have Fosamax, Actonil, Boniva, and Reclast. They're unusual because they accumulate in your bones. And after you take them long enough, you have an opportunity for what's called a drug holiday. And that means you can have a pause on therapy. You can have a sabbatical. You can temporarily get off of it because it may work for a while, even though you're not taking the medication. So often after somebody's been on Fosamax for 3 to 5 years, and if fracture risk is no longer so high, we might have a pause in therapy for a year or two. We would monitor things, and then sooner or later the effects would wear off and you need to get back onto some kind of treatment. So every medicine in the world stops working when you stop taking it, but the bisphosphonates stop working very slowly.
Okay.
And that's why we have this opportunity. So the idea is that if you're on a drug holiday, you might still benefit from the strengthening of your bones, but the long-term side effects may be less if you get off it a little bit less. So we tend to go light on these medicines and thinking about everybody's safety the most. And if we can accomplish our mission with a smaller dose of medicine, then of course we'd like to do it.
Thank you. And then the
But
last question.
Gail, I just have to say, because I have 2 more questions and we're out of time. So
Okay.
let me jump ahead. Dr. Lewiecki, can you address, first of all, breast cancer? I have a lot of people that have had breast cancer. Is it always that it always ends up that people will be taking a drug for their bones? Of course, it depends on what the DEXA test. That's the first question. And the second question is diabetes. If you have type 1 diabetes for 30 or 40 years, do you have information about that as far as bone health?
Well, for breast cancer, the biggest issue is taking aromatase inhibitor therapy. So this is anti-estrogen medicine, which is used a lot for breast cancer. It's very helpful, but it can be harmful for bones. So we like to monitor bone density very carefully in people who are taking this, and frequently they do need to be on some kind of medicine to protect their bones. And often that's either Reclast or Prolia. For type 1 diabetes, type 1 diabetes is a risk factor for breaking bones. So diabetics get more broken bones than non-diabetics. So we're especially careful to consider that as a risk factor, and we may be more likely to treat somebody with diabetes even at the same bone density than we would for somebody who does not have diabetes.
And does that play into the FRAX?
Well, it only plays into FRAX if you don't have a bone density measurement. So you can use FRAX with or without a bone density. And one of the beauties of FRAX is that it can be used in some parts of the world where people don't have bone density available.
Right.
So if you're in one of those places where it's impossible to get a bone density, then type 1 diabetes can be put into the FRAX calculator, and it will make a difference in the calculation. If you do have a bone density test that goes into FRAX, then it doesn't matter whether you have type 1 diabetes or not. The FRAX will come out the same.
Okay. Two other quick questions from Marilyn. If you have a fracture while on or after use of a bisphosphonate, will healthy remodeling repair be limited due to the lack of the osteoclasts?
You know, that's been studied very, very extensively in animals and in humans. And the bisphosphonates have no effect on fracture healing. So it doesn't help with fracture healing, and it doesn't harm fracture healing as far as we know. The one thing that is a little bit different, if you're on a bisphosphonate and you have a fracture, the callus around the fracture may be a little bit bigger than the callus around a fracture and somebody is not taking a bisphosphonate. But the strength of the callus and the speed of the fracture healing is about the same, whether you're taking it or not. And that's been studied in people who have recent hip fractures who were given a dose of Reclass, which is our most potent bisphosphonate, and they healed up their fractures just as well as people who did not get Reclass. So it's very safe in the setting of fractures.
And the difference between the T-score of the total hip and the femur neck on a DEXA, she's asking what the difference is. Does that make sense, that question?
Yeah, well, there's different parts of the hip that we call regions of interest when we do a bone density test. So the femoral neck is the bone density that's measured inside a little box in the neck of the femur that the computer places. The total proximal femur or total hip includes the femoral neck plus some other parts of the proximal femur. So we get different numbers for these different things. Usually the femoral neck T-score is a little lower than the total hip. When we're monitoring bone density over time, we tend to use the total hip rather than the femoral neck because it's a larger area of bone and it's a more precise comparison because of that.
Okay. And lastly, truly, but there are billions of questions in the chat. Here's a lady that is on a teriparatide. She's asking if you've ever seen anything like this. His CTX prior was 711 and her P1NP was 90. After 3 months, her CTX went to 2075 and her P1NP went to 653. Have you ever seen anything like that?
Sure. And congratulations. That means you're having a wonderful anabolic effect with the medicine. It's really revving up your bone cells to make new bones. So that's good. Those are good numbers.
It's good news.
That's
Okay.
higher than what we usually see, but sometimes we see very high numbers like that.
Okay. Thank you. Thank you so much. This was so helpful. We have so many other questions. I want to say a couple of things that somebody was asking about getting the full report. The full report is with the images. Do you distribute those images when you have patients come to you? You give them the images?
We do when patients ask for it, but we don't normally do it. It's a lot of pages, and frankly, there's a lot of confusing numbers, and unless you're an expert of these things, it's impossible to make heads or tails out of all the numbers.
But if you're getting a second opinion and you want to go to a certified densitometrist to make sure that your DEXA is well done, that's an important piece to have. Yeah.
Oh yeah, I mean, I like to have all the pages and all the numbers and all the pictures. So that's what I want.
And
But-
you're high on, or I don't mean to put words in your mouth, but the trabecular bone score, do you find that to be helpful as far as another diagnostic tool?
It gives me helpful information, and sometimes it makes a difference in how we treat things. I don't think it's essential. It's one little piece of additional information that can be helpful, and the more information I have, the better. But most of the time, we're going to decide what to do, whether we have the TBS measurement or not.
Because everybody's out there trying to get a TBS and it's very difficult. You go to places, they tell you they have it and they don't. It's very frustrating for so many people. So Dr. Lewiecki, really, thank you very, very much. And lovely compliments are coming in the chat as far as thanking you. And how was this for you?
I love it. I love the questions, and it's nice to talk about bones, and I enjoy this very much. And people always come up with new questions that causes me to think more and to look into things that I hadn't even thought about before.
I'm
So,
always intrigued how informed the overall consumer is, curious and informed. So this is just great.
well, thank you for having me, and I'm sorry we can't get to all the questions.
I know, I know. All right. Thank you again. Take good care. And
Okay.
bye for now.
Thank you.
Bye-bye.